For monitoring, that is to say, once you've made a diagnosis of alkaptonuria, surveillance should occur every 1 or 2 years over the age of 40. And that includes the echocardiogram, because there can be aortic dilatation and aortic or mitral valve stenosis, which can be detected on the echocardiogram. In addition, because the prostate and kidney stones, a urological evaluation should be obtained after 40 years of age. At least being aware of this is important for your urologist if there has been an occurrence of a stone already, whether it's prostate or kidney. And the ochronotic prostate stones can appear on a radiograph because they are radiodense. And the kidney stones can be identified on ultrasonography and with especially a helical abdominal CT scan. Dr. Introne has noticed over the years of studying patients with alkaptonuria that they have thyroid ochronosis. In other words, there's accumulation of the homogentisic acid in the thyroid gland, and there can be abnormalities of free thyroxine as well as thyroid stimulating hormones. So they should be monitored for hypothyroidism every couple of years. In addition, physiatry, or the people who examine our bones and joints, should evaluate our musculoskeletal systems of individuals who have alkaptonuria. And there should be stretching and mild exercises prescribed for individuals with alkaptonuria for the purpose of maintaining their connective tissue. Orthopedic surgery plays a huge role in this by basically providing joint replacements. And many of our patients have shoulder joint replacements, hip replacements, and knee replacements. Some of them will have 4, 5, or 6 of those different joints replaced. And the joints do well. But I must say the orthopedists are generally reasonably surprised when they see all the black in the joints in the bone. Pain management is very important. I'm actually going to ask Wendy a question. Do you think pain management generally requires opioids, or do you think that people generally get by with like ibuprofen or acetaminophen?
It's a combination, actually. It's a very personalized decision. There are some individuals who, for a variety of reasons, non-steroidal anti-inflammatories such as ibuprofen are contraindicated. And so those individuals then do need to use opioid medications. But whenever possible, we try to avoid opioid prescriptions if we can manage it with a non-steroidal anti-inflammatory. We always have to be mindful of the duration of time that patients are on anti-inflammatory medications, because we need to be mindful of the impacts on the renal system.
Important safety information. Indications. Harlequin is indicated for the reduction of urine homogentisic acid, HGA, in adult patients with alkaptonuria, AKU. Important safety information. Do not prescribe Harlequin to patients allergic to nitisinone or any other contained ingredients. Warnings and precautions. Ocular symptoms and hyperkeratotic plaques due to elevated plasma tyrosine level. Ocular signs and symptoms including keratitis, corneal opacities, corneal irritation, corneal ulcers, conjunctivitis, eye pain, and photophobia have been reported in patients. Perform slit lamp examination prior to treatment and regularly thereafter. Re-examine patients if symptoms develop or tyrosine levels are greater than 500 micromoles per liter. Assess plasma tyrosine levels in patients with an abrupt change in neurological status. Perform a clinical laboratory assessment, including plasma tyrosine levels, in patients with an abrupt change in neurological status. Leukopenia and severe thrombocytopenia. In clinical trials, patients with hereditary tyrosinemia type 1, HT1, treated with another oral formulation of nitisinone and dietary restriction, developed reversible leukopenia, thrombocytopenia, or both. No patients developed infections or bleeding as a result of the episodes of leukopenia and thrombocytopenia. Monitor platelet and white blood cell counts during Harlequin therapy. Adverse reactions. The most common adverse reactions, greater than or equal to 1%, reported in patients with AKU taking nitisinone in clinical trials are elevated tyrosine levels, thrombocytopenia, and keratitis. Drug interactions. Nitisinone is a moderate CYP2C9 inhibitor and a weak CYP2E1 inducer. Potential clinical impact of Harlequin administration with CYP2C9 substrates. Reduce the dosage of the co-administered drugs metabolized by CYP2C9 by half. Additional dosage adjustments may be needed. Nitisinone is an inhibitor of OAT1/OAT3. Potential clinical impact of administration with OAT1/OAT3 substrates. Patients should be monitored for potential adverse reactions. Use in specific populations. Pregnancy. Limited available data with nitisinone use in pregnant women are not sufficient to determine a drug-associated risk of adverse developmental outcomes. The background risk of major birth defects and miscarriage for the indicated population is unknown. All pregnancies have a background risk of birth defect, loss, or other adverse outcomes. Lactation. The developmental and health benefits of breastfeeding should be considered against the mother's clinical need for Harlequin, along with potential adverse effects on the breastfed infant from Harlequin or from the underlying maternal condition. Pediatric use. The safety and effectiveness of Harlequin have not been established in pediatric patients with AKU. Geriatric use. Insufficient data from clinical studies of Harlequin to determine if patients greater than or equal to 65 years of age respond differently. Elderly patients should be cautious reflecting any decreased hepatic, renal, or cardiac function, and of concomitant disease or other drug therapy. For more detailed information, please refer to the full prescribing information at harlequin.com/PI. To report suspected adverse reactions, contact Cycle Pharmaceuticals at 1-855-831-5413 or the FDA at 1-800-FDA-1088 or www.fda.gov/medwatch.